Thank you, Andrea. And it really is a pleasure to be part of this team. And it's really hard to follow these distinguished speakers, especially Kate Ackerman, who flies a mile a minute. I'm not going to talk quite as fast. But I have no disclosures for this talk, but I have a disclaimer. I am not a dancer. I've never been a dancer. I'm pretty sure I don't have rhythm, but I'm going to try to talk to you about what I do and how that relates to the field of dance. That is actually my second-year resident. She is a former professional dancer. She danced for 1 year, and it was very difficult, and so she's undergoing a second career as a podiatrist. She's currently training at Beth Israel Deaconess. So Professor Ruth, you might want to make some comment on her technique, and I'm happy to bring it back to her. But not only do ballet dancers have foot problems, all of our dancers, all of our athletes, I see an enormous amount of ballroom dancers, Irish step dancers, and really the feet are the foundation of the body. And it takes a lot of strength, it takes a lot of beating, and so that's what my role is. And today, I'm going to talk to you about some of the more common everyday problems that our dancers face, including ingrown toenails, corns, calluses, subungual hematoma, which is really just a fancy word for some blood underneath the toenail, and you might be familiar with these in your runners, as well as bunions. So let's start off with ingrown toenails. What are the causes of ingrown toenails? Because it's important to figure out what caused these in order to prevent recurrence. The first one is probably improper nail cutting, and this is an individual who's tried to remove the ingrown toenail themselves by doing what we call a slant back. And instead of actually correcting the deformity, I think they've made it worse by creating a new point of contact within the skin. So other reasons, poor fitting shoes. These might be ballet shoes, these might be too snug, or picking disorders. Sometimes there are kids, dancers who are anxious, and one of the things they do is start picking at the borders of their toes. And finally, an inherited condition. This can definitely be a source of chronicity, and so if there is an inherited condition, then we need to likely consider a more long-term solution. So let's look at the different ways that an ingrown toenail can present. The first one is very mild, and you can see that there's probably been some improper cutting going on, cutting back a little bit too much in the border. You can see a little bit of swelling, maybe some redness in this area, but it's pretty mild in the spectrum. The second one is where the skin has actually been violated by the nail plate. And when that happens, think of the skin as the barrier to bacteria. When this is intact, you can't get an infection, or you usually don't get an infection. However, when that nail violates that skin, it allows for the bacteria to come in, and sometimes you'll get a little pus pocket on the corner. And in more severe cases, it drives down a little bit more into the proximal nail fold, and you can see how the cellulitis, the redness, has extended to the next joint. And finally, in more severe cases, hopefully you never see anything like this, where this has been going on for a long time. You see hypergranulation tissue indicative of chronic irritation, and this is someone who's probably neglected this, has put this on the back burner. So what about treatment? What can we do? So let's say you have a dancer and they have this mild ingrown toenail. Well, usually I start off with very conservative care. I try not to go digging in there. And if we go digging, I usually like for them to be in the office in a controlled environment instead of their bathroom. There are a number of dancers who think that they can, or who might have found success earlier and try to replicate it, but this is when you get into trouble. So warm salt water soaks. People always ask me, is it Epsom salt, table salt, really salt, sodium chloride, salt. Whatever you have at home is fine. Triple antibiotic ointment. This has two purposes. The first one is that it's antibacterial, so any amount of soft tissue infection you could potentially treat with a topical. And also it's moisturizing. It helps soften up that nail fold, the skin around the nail, in order for the nail to grow out and glide. And finally, allowing the nail to grow out. That's really important in order to prevent this from occurring. What about these over-the-counter products that are advertised, or antibiotics? I personally have never used this Dr. Scholl's ingrown toenail pain reliever, but look, 4.5 stars. This is off of the Walgreens. So it must work, but when I started digging around, this is sodium sulfite, and it's an acid. And the idea behind this is it softens the nail so that you can actually go back in there and cut it. So I don't know if any of you have ever used this, but the FDA banned or had a warning on the label initially because this is an acid, and if it gets onto intact skin, you can actually cause a burn. So Dr. Scholl's, they're pretty smart people over there, and they have a little cup or a reservoir, and what it does is that you put it over the intact skin so that way the sodium sulfite acid only is applied to the nail plate that you're treating. So I don't know that, I wouldn't say use this, but I also don't recommend it. Also, what about antibiotics? Sometimes I use antibiotics on these infected ingrown toenails, sometimes I don't. I would say for a young, healthy individual, I do not. But the key is removing the offending nail border. And so let's talk about removing that offending nail border. And this is usually done in the more moderate to severe ingrown toenails. This partial nail avulsion is performed, and the important thing is that we have to go all the way back to the proximal nail root. You can't cut into this side here because then what happens is that you create a new angle. So it's really important to go all the way back here, and you can see this pictorial cutting all the way back, and you remove that. It takes about 3 months for that nail border to grow out. During that time, the inflammation comes down, the swelling comes down, and then when the nail is growing back out, it can glide out more smoothly. You're probably thinking to yourself, wow, that looks painful. How do we do that? Well, you really can't do that without blocking the toe with a local block. And I usually do this with a local anesthetic in the office, 1% lidocaine, 0.5% marcaine for a longer lasting block. Usually after this type of procedure, they usually can go back to dance that night, the next day. There's really not a whole lot of downtime. So I don't hesitate to perform this if there's an ingrown toenail. So, second disclaimer, I have a lot of gory pictures and a lot of gory videos, so if you are offended, I apologize in advance. So how do we do this? Yes, I know, I was traumatizing my poor husband this morning by showing him this. Well, I have special tools, so it makes it super easy for me. I have a spatula, and that way I can separate the nail plate from the soft tissue that's adhered to it. And I also have this fancy English anvil, which is flat on one side. It's a nail clipper. You can see I'm going all the way down to the bottom, and it's really important to go underneath the cuticle because the nail plate goes underneath there, and then we pull it out. And look at all of that nail underneath that lateral nail fold. So pretty impressive, incredible relief after that's done, and it's a great procedure. But what about that poor person who has this inherited trait, wide nail plate, sort of or a fleshy toe, and they keep getting these ingrown toenails? Well, we do the same thing, but at the end of that previous procedure, I do what we call phenomatrixectomy, which is where it's a fancy Q-tip, it's got a little acid in there, and we burn the nail root. The nail root is underneath here, and so that nail root never grows back. And instead of having a very wide nail, now you've narrowed it. So it's kind of like liposuction of the nail plate in a way. So this tends to treat. Usually I use the rule of thumb is 3 strikes you're out, 3 ingrown episodes, and then we really need to consider this chemical matrixectomy. Now the problem with this is the downtime's a little bit more. You have to soak in warm salt water for about 15-20 minutes every day for about a week, and then there's a dressing on it. It's a little sore, so probably no dancing for about a week after this. So this is really a planned procedure, and maybe some downtime when the dancer has that moment to rest. What about other prevention techniques? You guys have probably seen dancers stuffing cotton underneath their toenails. Well, this is a successful procedure. The caveat is that it's very lengthy and it has to be repeated daily. You can use cotton, a little bit of cotton ball. People have used lamb's wool. Dental floss. I've never seen this, but apparently it is reported. You can use dental floss. Toothpick? Never seen that, but that was, it's pretty aggressive. I think that's working. Lengthy treatment, repeated daily, and the idea is you're coaxing that toenail out, allowing it to grow out, cutting it more square. So a lot of people ask me, well, how am I supposed to cut my toenails? I go to the pedicurist, they round it out. I'm not entirely sure how to do this. Great question. Everyone's toenails grow differently. Everyone's shape of the toe is different. This may not work for you, but my recommendation, if you've had an ingrown toenail, is that you need to square it off. Make sure that you see the edges, you see the corners, and not to round it off like this. So that's the proper technique. But again, everyone is different. Sometimes it does take a little eyeballing, a little bit of practice to get it right. So let's look at corns and calluses. This is another big topic for me. I see this a lot. And usually what happens is that we call them kissing lesions. One toe rubs against the other, tight shoes, anything sort of snug squeezes them together, and they get this painful lesion. You might think, oh, a corn, I've seen those. Very painful, because think of it, it's like a rock in your shoe, and that's a sore point. The important thing to remember that these tend to have underlying bone deformities, and that's why they occur. The two bones are squeezing the skin in between, and that's why you get that lesion. Very common areas in between the fourth and the fifth toes, another common area between the first and the second toes, and also just on the outside of the fifth toe, all areas of bony prominences. So how do we treat them? So there's 4 ways that I address these. The first one is debridement, and that means removing that hyperkeratotic tissue, that corn tissue, in order to offload that to make it feel more comfortable. Drain fluid. This is an area where you can develop a blister. There's a significant amount of shear force. You can also develop some infection in that area, and so it's really important to treat infection. And I'm a little bit more aggressive in terms of prescribing antibiotics for these infections, because there's very little tissue between the skin and the bone and the toes, and so the last thing you want is to deal with a bone infection down the road. And finally, cushioning. This provides relief of pain, but it also prevents that shear pressure from creating that hyperkeratotic lesion again. Oh, and so back to these corn removers. Again, I didn't get the rating on this particular product, but people have told me that it works. You just have to be really careful with these, because what happens is that they come in this big, and then your lesion is smaller, and so you're treating a much wider area, and these can actually cause burns. So I also have another practice where I treat diabetic patients, and we see at least a few times a year where someone has used this, developed a bad ulcer, some infections. So I always, I don't discourage, but if you should go this route, always with caution, and to check on it regularly. My preferred method is sharp debridement with a 10 blade, and I'll show you. People always ask me, well, if I want to do this at home, pumice stone, a little foot file, how do I know when to stop? Great question. Stop obviously when you see blood, but hopefully you'll stop before then. And a good rule of thumb for me is pink skin. When it pinks up, you're good. So just a little video again. I don't think this is quite as dramatic, but I think you can see how deep these lesions can be and why they can be so painful. So here I am. I'm sorry, this is my medical assistant, wonderful medical assistant, but obviously she doesn't have a future in filmmaking or as a surgeon, given the steadiness of her hands. But here we are trimming down this corn, and you can see there's a central area of nucleation, not uncommon at all. In these areas, those can be very painful, so it's really important to remove that central nucleation as well. And finally, draining the fluid and treating the infection. So this is a blister. Obviously, it has a little pus in there, so we've drained it, we've opened it up. Really important to flush these out. What kind of antibiotics do I use? I usually, this is a skin, soft tissue, simple infection, I'll start with the first generation cephalosporin. For my penicillin allergic patients, maybe trimethoprim or clindamycin. 5 to 7 day course is usually sufficient. And cushioning the bone prominences. Now this is generally helpful, but it can also create increased pressure. So always proceed with caution with this. Oftentimes I'll tell my dancers to wear these when they're a regular person, meaning wearing shoes, walking around, just to help prevent the friction that's causing these lesions. However, when they're dancing, these can really impair their ability to dance and perform, and so oftentimes I don't recommend these when they're dancing, especially this type, because it tends to flop around. They find it in other areas of their foot. Sometimes difficult to find in the drugstore. I will direct patients to go to the drugstore. Sometimes difficult to find. Footsmart.com. I feel like you can find anything online now. Amazon, and so I tend to have a list of places that they can purchase these devices. Next, we're going to go to that sublingual hematoma. So sublingual hematoma is usually due to trauma, chronic repetitive trauma, sometimes acute trauma. I've had people drop things on their foot, and this occurs. So this is one where the proximal nail fold, where the skin, you have a hematoma. So just proximal to the nail plate, probably will lose this nail plate. And this one is where it encompasses both the nail and the proximal nail fold. Incredibly painful injuries. And the important thing to remember is that these are fluid, there's fluid underneath the nail plate, and this is just a very confined space. And so there's a lot of pressure, a lot of pain related to these. So how do we treat these? Well, the important thing is to drain that hematoma. That will give you almost instantaneous relief. And how do I do this? Very simple, prepping the nail with a little alcohol or betadine, and using an 18 or 19 gauge blade, you can, or I'm sorry, a needle, you can actually just use the bevel of the tip of the needle and just slowly swivel it around. I've also used a cautery unit. The only problem with the cautery unit is when it goes through the nail, there's like this volcano of blood. It's a little bit fearful at first. And certainly this is something, once you get comfortable doing, you can continue drilling these. I know Heather Southwick has done this recently. And then what you do is, once you have that hole, you sort of gently press on the nail. It's a little uncomfortable at first, but then you have this little fountain of blood, and afterwards, you know, incredibly grateful dancer patient. So again, disclaimer, a little gory. So this is the sublingual hematoma, and this one I'm just using a little 15 blade, and you see how you have the rivulet of blood coming out, and I'm just gently pressing on that nail plate to ensure that there's adequate drainage. Sometimes if it's a nail plate, especially the hallux toenail, I will do a couple of different drill holes just to ensure adequate drainage, because one may not be enough, or sometimes the blood clots, and then you lose the hole for the blood to exit. The other thing that you want to be careful about, not with the chronic repetitive ones, but with any sort of acute injury, is a possible laceration of the nail bed. So in some instances, you do have to remove that nail plate, and then just always inspect this. If this is what you see, they probably need to go to the emergency room to have that sutured up. Finally, hallux valgus. I totally appreciated Professor Ruth's reference to the article. I think this is something that we see a lot in the dancers, but there's very little evidence-based medicine regarding this. So I think it's really important that we understand that this is not only a bone deformity, there is soft tissue alignment, there's a joint that's involved, and there's many sources of pain. In my other practice, I do bunionectomies. I do the osteotomies. We fix these, and I can guarantee you that no matter how well the procedure went, everyone has stiffness afterwards. Everyone. I send it to my PT colleagues to work it out. So in our dancers, this is not an option. Surgery is not an option. So what do we do? What are my goals when I see this and someone comes in and they have a painful bunion? Well, my main areas of treatment is treat the inflammation. What happens is that they will have inflammation in this medial eminence where that bump is. There's a nerve that runs here, the first digital proper medial nerve, and oftentimes it gets impinged between the shoe and causes some numbness, sometimes some neuritic type pain. And decrease the pressure. And what this may mean is some padding in their shoes, and their dance shoes, and everyday shoes, because it really is trauma that continues even when they're not dancing. Because these dancers, I mean, they're stylish. They wear nice shoes. And I like that. So let's talk about what we can do in order to help them to continue their career, to continue to dance, and addressing these issues. First one, physical therapy. Where's Cynthia? Throwing you. Physical therapy is terrific. Intrinsic muscle strengthening, ultrasound. I mean, you guys can probably tell me exactly what you do that helps. It really, really helps. The important thing to remember is that it does not address the bony deformity. They will always have that bunion, but hopefully they will have decreased pain, allowing them to continue to function. Orthotics, in their everyday shoes, it helps. There's some evidence that it helps realign the joint a little bit, decreases some of the pronation that may be contributing to the development of the bunions. Padding, these and strappings. You can see this is a yoga toe. Again, I'm not entirely sure what it does. I think it stretches out the toes. It will not decrease the progression of the bunion. It will not correct the bunion, but what it will do is kind of stretch out the joint. And a lot of people have actually anecdotally told me that they've had relief with using these these type of paddings. Anti-inflammatories, NSAIDs, ice, all of the things that Dr. Stein talked about earlier today. And finally, a cortisone injection. I don't do these frequently. This is sort of like a last-ditch effort for me. If they have a performance and it's really hurting them, every once in a while, I might consider a cortisone joint, not a cortisone injection, not in the joint, but along that medial nerve if there's a nerve impingement going on. And thank you very much for your attention today.